Alrighty. Thank you so much for that opening there, Allison. I hope everyone can hear me and see my slides. I'm really excited to be here tonight, so thank you all so much for joining us as we go over optometric care and considerations for individuals with disabilities. I want to introduce myself first. Hi, my name is Dr. Jem Martin, and I am an assistant professor at the New England College of Optometry, or NECO. We're based out of Boston, and I do most of my clinical work at the NECO Center for Eye Care, the Perkins School for the Blind in Watertown, where I largely serve children who are visually and multiply impaired, which will be largely our discussion tonight and kind of the background for a lot of the care that I provide. And I also do work at our NECO Center for Eye Care at Commonwealth Avenue, working more with adults post-traumatic brain injury. So that's a little bit of where my expertise is coming from tonight. I'm excited to share with you all. I know we have some OTs and PTs out in the audience, and I often work often alongside other folks with a lot of the kids I work with. There's oftentimes I'm reading OT notes, I'm getting referrals from PTs, and I'm kind of hearing a lot about some of the visual concerns and things that are being picked up. And I hope that with our discussion tonight, we can increase our knowledge a little bit about the eyes, the ocular system, and things like that. So without further ado, we'll hop right on into it. I always kind of like to start my talk a little bit with discussing barriers to care and kind of underscoring a lot why, I do the work I do with the patient population I work with. I really like this review that really looked at not only the provider point of view, but the patient's point of view, and what some of these barriers to care that individuals with disabilities are facing when it comes to accessing healthcare. And, patients are often complaining about things such as communication or even attitudes and negative attitudes from providers in working with them. We often hear and are no stranger to concerns around financial situations, as well as just general ability to get there from transportation and organization, and all the way just to the availability of the service to be provided to them. When we kind of look at what our providers are looking at, we see things such as similar things like communication. How do I speak with my patient and make sure that we're all being understood and following, as well as just a general lack of training and lack of resources. It's this right here that I really feel fortunate that I work with the New England College of Optometry, as I get to work with several different students throughout their time in their optometric training and ensure that they're able to work with individuals who have disabilities and be able to provide eye care to anyone who needs it. As we wrap up the provider concerns, we see things such as just physical barriers, such as the healthcare system not even being able to physically serve the individuals with disabilities, depending on how they present. So I always like to keep this in the back of my mind as I work with individuals who have varying disabilities in order to make sure that we're addressing all those concerns and staying on page together to provide them care and ultimately the best vision outcomes and success in life. So as we get started, I wanted to spend just a little bit of time talking about the eye. I'm going to briefly go through anatomy, some of the bigger things that you might see as we walk through it, and hopefully this will help orient us as we continue on through the talk tonight. Anytime I talk about the eye, I always like to go from the front to the back, so we'll start simply, I think even more, with the refractive error, or that need for glasses. You may be familiar with the terms things like myopia, which are nearsightedness. Those are things that are up close or near, or farsightedness, where the flip side is true, where the far things in the distance are clearer than what's up close. We also see things like astigmatism, and this is just a fancy word that basically means that there's two focus points, and that leads to all those blurs or stretching or doubling of vision in all distances. Something that we see a lot with children, especially those who have different visual or multiple disabilities, is something that we are concerned about called amblyopia. And this is a fancy term that basically means unequal visual acuity between the eyes. And this could come from another reasons. This could be related to refractive error and the need for glasses either not being addressed or being very different between the two eyes. Could be related to strabismus or an eye turn, which we'll talk about in a few slides, as well as opacities or things that are physically blocking that eye from being able to be seen. Anytime we have this kind of concern or see these factors come up, we start to worry that one eye is going to become a little bit stronger than the other eye. If one eye is getting a clear image, either from not needing glasses or being able to look straight ahead, it's going to develop stronger connections to the brain and slowly become a favored eye. When we see this happen, we want to actually do treatment that will strengthen the weaker eye and strengthen those connections between that eye and the brain. We can do this as pictured here from wearing an eye patch or even doing eye drops that cause the good eye to become blurry and then basically have the child rely a lot more on the eye that's a little bit weaker in order to continue to strengthen those connections in order to equalize the acuity between the two eyes. It's always important to note that for anyone working with anyone who has amblyopia or strabismus and are undergoing patching or eye drop therapy, that oftentimes these individuals are not binocular. There is a loss of depth perception, as well as they're likely going to be using slightly less acuity and have blurrier vision. And all those are considerations to have whenever a child might be patching and might not be being able to utilize the better seeing eye. As we move on from the need for glasses, we can start at the front of the eye or that interior segment. And I always think about that as simply anything you can see for the most part when looking at another person. These are things like our eyelids, our eyelashes, which you all will be no strangers to things such as styes or what we call hordeolums, which are essentially pimples of the eyelid. These can be either on the inner eyelid or the outer eyelid and definitely crop up from time to time and isn't necessarily anything to be concerned about and it typically goes away pretty quickly. But things like recurrent styes or hordeolums might be concerning and be something to look out for. As we move forward in the eye, we have our conjunctiva, and this kind of refers to two different parts. We have our palpebral conjunctiva, which is that inner eyelid or the pink areas, and then we have our bulbar conjunctiva, which is the white part of the eye and abuts the sclera. And as we can typically, when we think about the conjunctiva, we're thinking about things like conjunctivitis, those goopy eyes that we can see in children when we have bacterial conjunctivitis. While when adults, we typically see more of a weepy, virally based conjunctivitis. Both of which are contagious, so we definitely want to make sure that anyone that we have suspected with conjunctivitis or pink eye is making sure that they're being treated and also having all of the things that they touch cleaned up, as well as making sure that they're not touching their eye. Moving forward through the eye, we have our cornea, which is that clear front surface of the eye that kind of makes that bowl that goes out over the front of the eye. And as we move forward from there, we have our iris, which is, of course, the color portion of the eye. And in the middle, there's, of course, our pupil, which is always funny when I think about it because it's not actually a structure, but it's something we think about pretty frequently. Oftentimes, when we see things like unequal pupil size or anisocoria, we can be concerned that might be neurologic in cause, or perhaps is it related to a medication that they're taking, or perhaps if it's always there, it could just be the way that their pupils are differently sized. We always want to make sure that we're looking for stability there, and any kind of new onset anisocoria or pupil size would be a cause for concern. As we move in, we have our crystalline lens, which is just right behind that pupil and iris inside the eye. And oftentimes when we think about the lens, we're thinking about things like cataracts, which can be from many different things, such as aging or more traumatic in nature, as well as congenital. And should these children still have a cataract in there, you would have concern about amblyopia, as we spoke about earlier, given that opacity that's there in the eye. As we move on from the front of the eye, we then move into the inside or that posterior segment. And what makes up the majority of that is the retina. So anytime us eye doctors put eye drops into your eyes and make you all light sensitive and blurry, this is because we want to look at the health of the inside of the eye. So as you all know, that retina is that sensory tissue that lines the inside of the eye and takes all that light information and sends it out to the back of the back of the eye, out the optic nerve into the brain, so that way it can be processed into what we see. There's kind of two areas I think about when we look at the retina, and the one that we often think about highly is our posterior pole, which is our kind of area of central vision, or that macula, as I have pictured here. We have everything happening here, as you can see there in the center of that macula, we have the very dark spot, which we call the fovea. That's actually a very thin layer of retina tissue there that allows for that fine detail 20/20 vision. Anytime you're looking at something, that dot right there is what you're aiming your eyes to focus on in order to see it. Now, if we look to the right of our eye, we have the optic nerve, that kind of pinky orangey circle there, and all of the little vessels coming out of that are, of course, our blood vessels. It's always fun and very interesting. My favorite fact about the eye is that it is actually the only part of the body where we can visualize blood vessels directly without having to make any kind of incision. And that is actually what allows us to screen for things like diabetes, hypertension, cholesterol, things like that. So make sure you're getting your dilated eye examination. When we think about the peripheral retina, that's just gathering, of course, our side vision, and something that anyone's very concerned about is going to be a retinal detachment or that tissue pulling away from the globe of the eye. This is something that we consider to be sight-threatening. This can be lead to permanent loss of vision and blindness if not caught in time and treated appropriately. So oftentimes when we're thinking about things like our retinal detachment, those when the doctor asks you if you see any flashes of lights off to the side or increases of floaters or bugs in the vision or any sudden loss of vision. Now, I'm often asked, because I work with individuals who have various disabilities, including some that allow them to not be able to communicate as clearly, we often say, well, how do we know if there's a retinal detachment there? And I often think about, well, is there any kind of change to the use of visual function? We used to be able to navigate, and all of a sudden we're not able to. I've had a child who, after a retinal detachment, went from walking to feeling more safe crawling on the ground, and everyone was not quite sure what was the reason for the regression in the behavior until they realized that there was a visual component, and he felt much more safely being on the ground, where he could feel much more rather than looking into nothing that he couldn't see. We also hear about concerns about not being able to see, especially at night, or kind of seeing changes in contrast and kind of complaints around those areas. So those are all areas, especially if sudden onset and without any other explanation, might warrant something such as a retinal detachment. And we definitely want to make sure that we're getting our eyes dilated and being checked out for that. Now, the other part that I mentioned earlier, that optic nerve posterior pole area, is that optic nerve, which is that connection from the eye to the brain. So whenever we think about the optic nerve, typically we think about things such as glaucoma being one of the bigger kind of diseases that happens to the optic nerve, where that increased pressure slowly pushes that optic nerve, that slowly kills all of the different fibers there that leads to that loss of vision. Now, we're not typically seeing glaucoma within children, but it is not uncommon to have congenital glaucoma. However, more oftentimes we're seeing things such as optic nerve atrophy, which can be related to brain damage that happens either in utero or after. We can also see repeated insult to the optic nerve can also end with an optic nerve atrophy. So end-stage glaucoma does typically end up looking like that due to the complete death of the optic nerve. Similar but not quite the same is a smaller underdeveloped optic nerve, or which is a hypoplastic nerve. And these generally are just a little bit smaller and may have no impact to the acuity or visual field, or may be very impacted, similar to those who have optic nerve atrophy. We can also see hypoplastic nerves kind of being in isolation, as well as being related to underlying conditions such as septo-optic dysplasia. As we wrap up here, I always like to make sure that we mention functional vision, and more specifically strabismus, which is our fancy optometric word for an eye turn. Anytime we see a kind of eye turn, we automatically know that we have a lack of depth perception because both of the eyes aren't pointing in the same direction. With strabismus and eye turns, we can see things such as double vision, and especially if the strabismus is later onset. However, those who are a little bit younger and have had strabismus from a young child, instead of that eye developing typically, as we spoke about earlier, it might do what we call subpression and even just completely shut off the eye and completely rely on that eye that's well aligned and is stronger and better connected to the brain. So again, this will have impacts to visual acuity, especially if one eye's always turned in and not getting good visual signal to make those connections to the brain. we know that there's no binocularity, there's no depth perception there for the patient to be able to fully appreciate. And we also wonder, is there truly single clear vision, or are we working with slightly double vision or slightly not completely clear vision? So with those in mind, I'd kind of like to start to move into how I approach the optometric examination with these kiddos, particularly based on my experience at the Perkins School for the Blind. I think it's always important to make sure that you're setting yourself up for success. So anytime I'm going into the examinations, I want to make sure that I'm reducing the chance for the kids to go and grab things. I'm always telling the interns I'm working with, our hair's tied back, we're not wearing ties, we're not having dangly jewelry. We also, even before kind of COVID, made sure that we weren't wearing white coats. And we tried actually to have an approach that was very much like, hey, we don't look like doctors. We're just wearing typical clothes. And really reducing that kind of onset and anxiety of like white coat syndrome and some of the kind of negative associations some of these kids have with kind of receiving medical care, unfortunately. What I always think is also important is that we're kind of thinking outside the box. I think it's always important to make sure that you have several different types of approaches to kind of get the same thing that you want done. So that way, if one approach isn't working, we can pull out another and keep on going. That said, if we don't have another approach, being able to kind of be flexible and think on the spot how we might be able to adapt or modify our approach can also be really beneficial. And then finally, a big thing I like to definitely do with the optometric interns I work with is really having us reflect on our successes and failures. You're going to have some wins and you're going to have some L's, and you're going to have to be able to take all of them in stride and be able to learn from the mistakes you have to continue to make yourself the great provider that you are. So at the end of all my clinic days, I always have my interns, reflect on moments that they were proud from the clinical day, and then what areas do they want to continue to work towards to continue to make themselves move forward in their optometric path. When working specifically with individuals with vision impairment, I like to have a couple of things in mind, and one of them being, you want to make sure that you're identifying yourself when you're entering a room. I always say, hey, Dr. Martin's here, how are we doing? And when you're leaving a room, you want to let them know that you're stepping out, so that way they're not expecting to have you in the room when they're looking for you and you're not there. You also want to make sure that you're speaking directly to the person. And this is always true if they have a visual impairment or if they come with their sign language interpreter or anything like that. We want to make sure that we're communicating with the patient at hand and not speaking over them or about them in front of their face. For those with visual impairment, we want to make sure that we give, when giving verbal directions, we want to make sure that the terms we're using are accurate and very direct. So we're saying it's right or left, or you're going to go 3 rows and then it's behind the door to your right, always relative to where the patient's standing. And that way that can help them orient where they are in kind of space and be able to navigate more independently without kind of concern about where objects are in space. And then the last thing we like to say is that it's completely fine to use phrases such as look or see, as they're kind of a part of normal conversation. So I know some folks get a little bit concerned when about kind of using some of those visual terms, but it feels a lot more awkward trying to dance around it rather than say, okay, let's take a look and go on in from there. Of course, working with individuals with disabilities, you'll have some different communication styles. So this may you'll want to make sure that you're leaving time for increased processing and response time. And, I've seen this taking a few seconds of really listening before understanding and responding to full minutes to fully process on several different levels what we were asking of the individual before gaining a response from them. I always like to make sure that we're utilizing, we're building good rapport with the patient as well as their team. Utilizing the expertise of their caregivers, of those who know the patient better, is always going to be a win. And I think that's always gotten me out of some tight situations where I perhaps was maybe making a child a little bit more upset with the lights in the eye exam, but boy, did Bluey get us right back on track after the parent's kind of recommendation there. So always making sure that you have those tools with what the patient also likes to kind of get their buy-in and continue that care throughout the time you're working with them is always important. And a big thing that I always like to chat with my interns about and kind of work with my students is, really thinking about our role. From my end, we're optometrists. From y'all's end, you therapists, OTs, PTs. You have this expertise and knowledge about what we're doing with the patient, and it's our role as that provider to be able to engage the patient in a way that they're able to successfully take part. I never think that the patient's uncooperative with me. I think it's more of the fact that I wasn't able to come up with a way to engage the patient in a manner that really connected with them for us to have a successful eye exam, and then move forward from there to be able to engage them at either at future tasks in the examination or at future examinations as we go forward together. Anyone who does a lot of work with individuals with disabilities know that there's probably a lot of history review that kind of goes in there, and that's no different from the eye examination end. So prior to even seeing the child, I'm getting a record request of their other optometrist, their other ophthalmologist notes. I'm wondering what their medical concerns are as far as, especially as it pertains to neurology or even some of their genetics. As well as looking at aspects of their educational review. So I'm looking at things such as their IEPs. What are we working on, and what are the kind of supports that we have in place and accommodations that we're making for our kiddos, as well as making sure that we're connected to the right services so that way our kids can be successful. I always like to make sure that I do a good review of kind of different comorbidities and other conditions, and definitely can get tricky for those who work with some of the more rare conditions. One of my favorite resources in this area is the National Organization for Rare Disorders, or rarediseases.org. I find that NORD has a lot of explanation about the different things that can be impacted in some of these different and rare syndromes that might present to you. And doing a little bit of digging before I see the patient gives me an idea of the potential visual concerns that may pop up as a part of the exam, or things that I might need to address that the family may not know about, given depending on the complexity of the patient. Of course, when the patient arrives, I want to take the history with their team and kind of see how's it going. I always, of course, want to know about our ocular status. Have there been any changes in our visual function? Do we have any big concerns? Another thing we want to make sure that I'm aware of is kind of the environment that the patient's working in, and making sure that it's accessible to them visually, as well as me having a very concrete idea of the recommendations I'll ultimately provide. If I'm working with kiddos in early intervention, my recommendations are going to be less about seated at the front of the classroom so they can see the board, and more about where might we sit in circle time to make sure that the child can see the book that's being read. Other things I like to look at, of course, are things such as mobility function, and kind of seeing how are they doing navigating. Are we mobile? How are we using our vision in those situations? And what areas might we be concerned about? As well as the use of any assistive technology devices or alternative augmentative communication devices or other. That way we can make sure it's accessible to them visually, as well as meeting the intended purpose that they are working with them for. And I mentioned earlier wanting to make sure you establish rapport and kind of get that buy-in with your patients. And oftentimes I'm no stranger to having a child kind of crying before even coming in. And, we really don't want to start on that foot. And really what I want to do is make sure that the child is very comfortable and feels acclimated to my space. So, I might start with playing a favorite show or music to kind of get the child to feel a little bit more comfortable making that transition from the waiting area into my examination room. I might let the child run around in circles. I had a kid today who ran in, looked at every single corner, and then came back and was like, all right, now I'm ready to go. And kind of giving them that time to take in their space can really allow them to be comfortable and feel more connected with what we're doing. Again, get that buy-in as we continue in as the examination. Another area that we might do is the use of social stories prior to the examination as a way to expose patients to different parts of the exam. So what do I mean by that? Social stories, and these are some of the examples we have at the NECO Center for Eye Care, kind of give a little bit of a background on what to expect in this case in the eye exam. So as we can see here, we have several different pictures. So that way, once it's reviewed a few times with the child, once they walk into the eye examination room in real life, they'll be familiar with the big chair. They'll have seen the funky phoropter device. They'll know what the eye drop box looks like and have a little bit more of that comfort in knowing kind of what's happening and it not all being a new big scary thing all at once. Now, big things that I do in particular with my role is kind of looking at how the child is using their eyes and kind of connecting it to their visual function and the diagnoses and the measurements that we get. And oftentimes we're looking at things, making a lot of these inferences through observations. As they come into the exam room, are they mobile? Are they using a cane? Are they bumping into objects using the railing? Things like that. Again, as they walk in, do they take in the whole exam room or are they only aware of certain areas? Already from the start, I can get a sense of how we're doing with our visual field and how are things looking and what concerns I might want to bring up with the family and their caregivers to see if there's any concerns there. Of course, our observations are going to continue through the eye exam, and this can be things such as subtle as head turns and tilts and kind of ways to adjust the use of vision. I have several individuals who have strabismus, those eye turns, and I often find that holding their head at a slightly different angle allows for their eyes to better align and provides for more single clear vision. We often see things such as gaze preferences, which we may leverage for things such as positioning in classrooms, as well as kind of the utilization of other senses for considerations for multisensory approaches to education. So kind of as we move now into the eye exam, I want to kind of go through kind of each of the sections that we're testing and kind of give some background on how we might go about doing some of the testing. So of course we start off with our visual acuity, and that's simply our detailed vision. When we say 20/20, that's what we're referring to. Within the United States, the level of legal blindness would be a visual acuity of 20/200 or worse in the better seeing eye with correction. There's also a visual field diameter of 20 degrees or less. And if you fulfill one or both of those, you are considered legally blind. Now, visual acuity is important for several different reasons. We want to make sure that we can see where we're going, see what we're doing day-to-day life. It's also used to monitor for disease progression, especially for in the cases of conditions where we want to make sure that there isn't progression or where we know there's progression to kind of monitor and make sure that we adjust as needed as things continue. We also utilize visual acuity to provide print size recommendations, as well as determine some eligibility for different services. When we take visual acuity, and this is where you sit down and read a bunch of letters off the screen, oftentimes we're looking at kind of alternative materials. So as you can see here, instead of looking at some letters, I have a child who is doing some symbol matching. And that's really beneficial to kind of allow decreasing the amount of perhaps verbalization, which takes more processing for our patients, and giving them as well a kind of reduced field to choose from, as we can see from there, can reduce further implications and visual processing difficulties from things such as visual complexity and things like that. I often, again, as I'm looking at a more functional use of our vision, and always kind of testing with both eyes first, just to see how we're doing in our everyday walking around, both eyes open fashion. Now, of course, knowing the individual acuities for each eye, especially in those amblyopia cases, strabismus cases, we'll want to make sure we get monocular or single eye acuities, which can be with a little paddle, or perhaps we're wearing a sticky eye patch and pretending like we're pirates, or perhaps I put tape on their glasses and they're not looking around it. I've had one very moody teenager who would only use his palm, and I said, all right, as long as you're not peeking, and we checked, it was all good. I mentioned earlier that we might not necessarily use letters, and we often see here, as I have pictured, some patty picks or Leia symbols, which are our general circle, square, heart, and house. And it's really great for pediatric patients or those with cognitive impairments. I've actually worked with several individuals and their team members on working on kind of identifying these shapes, which helps provide a more accurate kind of read on their visual acuity. As we saw in some of the pictures there, we might match on the matching card, and we can either give them an array of 4 or kind of do a 2 forced choice matching paradigm. And again, as we can have these up on the TV screen, or as we have on the bottom left, a picture of the lay of playing cards, where you can get near acuity. Now, for those who maybe aren't able to, who don't know their shapes or maybe aren't able to match, we then move what we call to preferential looking, where, as you can see here, we have a card where one side has the grading and then one side has nothing. Under preferential looking, the idea is that if the individual is able to see the stripes, they'll look to the side that has stripes, as that's much more interesting to look at rather than the blank side of the card. And whenever we start to see their kind of changing in fixation, difficulty determining which side, looking at both sides, we can determine that, hey, they're probably not seeing it anymore, and can make an inference on their visual acuity from there. Because the child only has to kind of look at either one side or the other, that is kind of giving them a 50-50 chance. We do want to make sure that we're doing kind of multiple testing and making sure that us, even as the provider, don't have an idea of where the grading card is or what side the grading's on, so that way we don't bias ourselves into thinking that they did look. Now, it's really great. Again, these may overestimate acuity because you have a 50-50 chance looking of getting it, as well as the fact that it's a lot easier to look at some stripes rather than look at a shape, remember what the shape is called, process what the shape is, get that out either via verbalization, via match, much more steps and much more cognitively involved, but also much more realistic to the use of vision in real world. We also have the grading cards, paddles, as you can see here, which work similarly to the teller cards that we had pictured on the previous slide. And as we move on into our contrast sensitivity, this refers to more about how bold something is in order to be seen. And I find that's important for a lot of different reasons. Things like mobility, we can see on the bottom, a washed out photo very much takes away from that child in the middle of the street with the ball, and that we certainly don't want that. But even from stairs, we can see at the top that kind of, even with clarity, it's very difficult to tell where one step ends versus the other when there isn't contrast. We also, of course, know that this impacts things such as lighting, reading. Newspaper print has really bad contrast. It's awful. As well as things such as facial recognition and just general object detection. And often I find that contrast sensitivity ends up being overlooked when it's such an important aspect of how we use our vision in day-to-day life. So some different ways that we may test for contrast. We, of course, have our Pelley-Robson card pictured in the middle that has several different letters that slowly fade away until they disappeared. So again, folks who are able to know their letters and point them out are able to use that card. We again have preferential looking tasks. So our hiding Heidi picture down on the bottom left, where they have to find a face that gets fainter and fainter. Or the Mayor Cran double happy contrast text picture on the right side, which was developed at the Perkins School for the Blind by my mentor, Dr. Barry Cran, alongside Dr. Louisa Mayer, pictured here. Same kind of idea as our teller cards, but instead of the gradings getting finer and finer, our smiley face gets fainter and fainter. But same idea, we show the card, and whenever the child stops looking at the side that has the face or changes up or seems a little bit more uncertain, we know that we have a pretty good idea of where their contrast sensitivity measurement is. Now, as we move into our visual fields, this is, of course, our side vision, but this can be broken down further into our peripheral vision and then our central vision. We, of course, use that central vision for things like reading, writing, walking around, facial recognition. And then our peripheral vision is, of course, used for greater mobility tasks as well as driving. So whenever we think about our visual field, we want to, again, I'm always thinking about testing it with both eyes open, because we want to know how the child's moving around when they walk in day-to-day life with both eyes open. Unless they are someone who patches, in which case I might want to know how they're looking, how their visual field looks whenever they are wearing the singular eye patch. Now, there's several different ways, and some of the traditional ways, including counting fingers, but for those where it might not work. As you can see on the bottom, we have some pictures where we have targets coming in from the side and seeing when the child averts their gaze to each side. We can also have simply using a different light and kind of making sure that they have targets and whenever they start seeing the light versus not. We have some of our more formal visual field tests on the bottom is our Goldman perimeter, which is kind of the previous old low vision way of doing our side vision, as well as the automated Humphrey visual field, which you all may be familiar a bit more with kind of having to click the button while sitting in the bowl. Again, I like to kind of do confrontations with both eyes open. So I like to, as pictured in both of these here, often I'll come from behind with another intern looking at the front, and we'll kind of introduce the lights from both sides and see when the patient either averts their gaze or, depending on what level, how old we are, cognitive level, able to point out when they're able to see it. I often find that testing in free space is much more beneficial for these kiddos. And then we also get to make sure that we kind of make it a little bit more of a fun game. Can you find the light to the side? Things like that. When we think of our central visual field, some of the traditional ways to kind of measure that include using an Amsler grid, which is just as simply a checker grid. And this looks for central changes in vision from things such as degeneration to the macula or central scarring or things like that. Again, I'm more functional, as you have all heard, so what I'll tend to do are what's called facial fields, as we have pictured here, and essentially have my patient, looking at my nose, can you see both my ears? Can you see both my eyes? Can you see my forehead? And kind of seeing, are there areas of my face that, I can only really see the left half of your face, or, I see both your eyes but not your chin, and can get an idea of what that central visual field looks like for the patient. There are some fancy and more advanced pediatric visual field tests. Pictured here, the LED hemispheric perimetry, which, as you can see here, the baby's looking into the bowl, and whenever the baby's looking straight ahead at the central target, an image is flashed to the side, and they see if the patient averts their gaze, giving an indication that they were able to see in their peripheral field. A very similar thing happens in the pediatric perimeter, where we have our child inside the dome, and again, we're able to monitor fixation digitally and then show that visual field images off to the side based on where the patient's gaze is at the time. As we move forward, we have eye movements, which are also called our motilities, and this is simply our ability to move our eyes freely and accurately. It's of course important for, looking at things, tracking objects as they're moving, having that spatial awareness and being able to take in everything that's around you. I always like to make sure that we have really interesting targets. So, with my kids, if I already know they like Mickey, my Mickey Mouse toy is out. If I know they like spinning lights, you bet I have the spinning light toy out. Something, since I do work with several individuals who have multiple impairments, I always make sure that, things like spinning lights, bright lights, things like that are okay for the child, and then that they're not a concern for triggers such as seizures, or is it going to lock in the child and you're not going to be able to get them out. I unfortunately had a patient who came in who really loved spinning light toys, and we brought it out 5 minutes into the examination, and we never got him back. So definitely knowing, again, leveraging the caregivers that are coming in can be really beneficial to make sure that you're doing things in the right order. But of course, other things I've done is have a video on my phone and have them follow it as I move around. Oftentimes, I'll even just pull out a mirror and say, hey, look at yourself. Who is that? And see, can they identify themselves? Are they able to keep that eye contact and kind of follow it as it moves around? Is there any interest in human faces as they see them? All good things that we can kind of get from basic, alongside looking at those basic eye movements that the child has. Color vision is, of course, that ability to see color accurately. Typically, when there's a color vision deficit, it's either a red-green deficit or a blue-yellow deficit. This, of course, is important for things such as object identification and within driving to make sure that we're able to recognize the different colors on the traffic lights and signs. For more formal color vision approaches, I often use the Wagner Color Vision Made Easy, which is pictured there in the center. And I really like it because, again, it has some of those really familiar shapes that kids are used to, square, circle, right there, a star. And we also have the little wooden toy that we have pictured there. And I give this child a circle and I say, find the circle. And he matches the circle. And all of a sudden, I have a really formal color vision test completed on a 2-year-old. And all we did was make it a matching game. For those with more higher concerns with color vision deficits or need a more quantified way, we have the PV16, which is pictured up top. And basically, the patient has to put all of those in order, going from that blue to that pink. And based on the order that the patient puts it in can give rise to letting us know the type of color vision deficit that they have. Now, as we move away from the formal test, we can, of course, use color chips, holding these up and say, what color is this? Red? Or I've done it where I've had the patient hold a color and then held up two and said, who's the same as yours? And did color matching that way. We've also have puzzles that we like to do, such as our fish puzzle here. Are they able to match and name those colors as we go? All the way to our kind of caterpillar there and making sure that they're able to name the colors or asking them to do certain patterns. Oftentimes, I'll pull out the light box as pictured up top, and I find this really beneficial for patients who have very, very low acuity or kind of low use of their vision in order to kind of increase that contrast and really make it bright and pop for them. So for those who have pretty poor acuity, I've been able to get an idea of the color perception, kind of utilizing the paradigm as pictured here with those kind of big translucent shapes in the backlighting there in a dark room. Now, of course, we have our binocular vision system, which we spoke about earlier, and that's kind of our ability to line up our eyes and maintain that alignment. So as we mentioned earlier, we can have eye turns in, those are esotropias, eye turns out, exotropias, as well as vertical deviations also being something that can occur. The binocular vision system is important to, of course, provide the ability to see single clear vision. We often see, individuals who have difficulty reading, kind of being able to stay on a line or pass from one line to the other, maybe have concerns with their underlying binocular vision system. We also, of course, know that if the eyes aren't working well together as a team, that's going to impact our depth perception and kind of take away from that 3D vision that the patient has as well. So within our kind of measurements for alignment, we'll often look at the way the light reflex appears off of the eyes. If they're not symmetric, such as at the top, that can give us some inferences that the eyes aren't well aligned without us doing too much being in the patient's face, if you will, to kind of measure the alignment in more formal ways. We'll also take a look at stereopsis, or that depth perception. And, for those who are able to pop on glasses, we might pull out our smiley face pass test, as we have pictured here, where one card's blank, one card has a smiley face. And if they have the depth perception, they'll be able to see the smiley face and kind of have that two forced choice approach. There are also some options that don't require glasses, such as the Lang or the Burnell evaluation of stereopsis test, which we find really great, especially for our kiddos who are a little bit more tactile defensive, who want nothing to do with you being in their grill, and being able to make sure that we can still get a measurement of that depth perception, even if we can't get those glasses on. Other things we look at with the binocular system is our ocular motor system, or those coordinated eye movements. And what we might do is simply have our patient look between two targets, as well as track a target and kind of follow the Ensuko grading for that. Or for those who might know their numbers and letters, pull out our developmental eye movement test, our DEM, or our King-Devick, which you may be familiar with, both of which are kind of reading tasks to kind of see how these saccades, or those small accurate eye movements, are doing for our patients. Now, bringing it all back into, of course, that refractive error, we spoke about that need for glasses earlier. And of course, that's going to give us clear single vision and also helps correct for any eye turns, binocular vision issues, and other concerns that patients may have. So, oftentimes what we'll be doing for our individuals with disabilities, especially those who might not be able to communicate, is it better one or two, is kind of look at some of our more objective testing, utilizing our lights and our drops in order to kind of make sure we're getting the most accurate measurement of their eyes. Again, we like to do all this kind of work in free space. We don't have the big phoropter that we're putting our patient behind, but instead using our trial frame as pictured here, or just using loose lenses or flippers instead of having the patient have to wear anything. Now, as we start to wrap up, we have our ocular health, which is important for everyone, of course. So we want to make sure that there's no diseases, there's no progression, as well as making sure that you're able to see. Of course, for our kiddos here, that free space, handhelds, not having us go into the chin rest, forehead rest situation is always going to be that buy-in for our patients. As you can see here, I've used things such as a high-powered magnifier. We have just lights that we've used, and just kind of making sure that we do it. You can even do it like out of the chair and on the ground on a mat, and it really makes it a lot less intimidating. And oftentimes what I do is say, hey, it's your turn to be the doctor. You want to look at my eye? And then while they're looking at my eye, I can easily turn it around on them. We're already in each other's faces, taking a peek at the health of each other's eyes. Just so you all know, we'll often use those kind of free space areas. So our intraocular pressure, often we'll use the eye care device as pictured here, which is a free space device. Also, you might just see us do a little bit of tap on the eyes and say it's all good, whatever kind of works for the patient's level of engagement. And of course, as we move into internal health, you know, for those who are familiar with the eye drops, we might use a combination drops instead of having to use multiple drops. For some of my older patients, I've actually said, hey, these drops sting. Do you want me to do a numbing drop so you don't feel it? And kind of get their, you know, opinion on how they want to proceed with their eye exam. A big thing that we always do is occlude the puncta, the little drainage holes on the eyelids there, just to reduce the risk of any systemic absorption of the eye drops. Now, the big thing here, of course, is, as you can imagine, it's not always possible to get the views or see everything that we want. And I always just say that documentation is your friend, and you want to make sure that you had a good idea of what was attempted to make sure that you have done the most that you can do for your patient population. I'm going to go a little bit into some of the modifications that I often use in the examination. My biggest one always being, you know, meet the patient where they are. You know, if there's someone who wants to have a ground examination, I'm getting on the ground. I had a patient who was terrified of the exam room. We did everything in the hallway until they were able to feel comfortable with me and my team and slowly get ourselves back into the exam room. I think that's the biggest way you're going to make sure that you have success, as well as continuing to grow that rapport that you have with that patient. Again, for those who are a little bit more tactile defensive, don't want to be touched, I recommend starting with things far out and then slowly moving on in before you have to really touch the patient, so that you, again, have that rapport with your patient. I often provide frequent breaks. We have games, we have dance parties, we have movement. You know, we take all sorts of times that we need for the child to be able to go for the length of the eye exam, which can definitely be a lot for these kiddos. But of course, while these things are happening, we want to make sure that we're observing and getting a good idea about how they're using their vision, even in those off times. Now, a big thing, as I mentioned earlier, is I might use myself as someone for them to kind of do an eye exam on. I've also had kids come in with their own toys, and I say, all right, looks like our doll's going to get a dilation drop today. All these ways to kind of model what might happen, so that way it takes out that mystery of what's going to be coming next for the patient, and they can see what's going to happen and anticipate it, rather than it being kind of a scary new task for them to do. Finally, one of my favorite ones is, you know, using kind of a distance fixation target. And whenever I'm doing that, it kind of allows me to do some work with health, kind of look at light reflexes and things like that, where I don't necessarily need the patient to be responding to me, but I need them to engage their vision so they have something fun to do. And then I'm the doctor where you get to watch Paw Patrol instead of get the bad eye drops. For those who have multisensory impairments, again, collaboration with the caregiver is great. You know, I've picked up a lot of sign language, especially those for some of the kiddos that I worked with, or kind of using their familiar communication device has been really beneficial for giving successful eye exams. As you all know, kind of narrating out what we're about to do, again, takes that mystery out of what's happening, and I find really helps the patients prepare and be ready for what those next steps are. As well as, again, kind of allowing for that chance to kind of acclimate to the room, acclimate to being touched, and kind of making sure that they're feeling comfortable with things before we go forward. So as I wrap up the eye exam, what are some of these outcomes that happen at these? Of course, we want to make sure that we're addressing the patients and caregivers' concerns, as well as just giving some information on their functional vision. I like to connect the testing approaches that we use, the environments, maybe if we had to change the environment and turn out all the lights instead of having the lights on, and make those connections to things that they can do to support their child at home, at school, or in those other vocational settings. I often see concerns around glare, and kind of making a quick change as simple as not making sure that we're not underneath a bank of lights or next to a glare source as a window can be really beneficial for some of our light sensitive kiddos. As always, we want to make sure everyone's aware of what the follow-up is, but beyond that, we want to make sure that the connection to the other care providers that they're working with is still there. We want to make sure that they're going to maintain care with their ophthalmologist, especially if it's been a couple of years since we've last had those eye drops. Sorry, we do have to do those, and making sure that the retinal health remains intact. Of course, we also want to make sure that we're collaborating with the non-physician professionals. We want to be talking to the educational team. We want to be talking to those who are in their rehab or day programs, as well as making sure that they're connected to the assessments that they have to have. And what comes out of ultimately my examination is a report that I encourage my patients and their family members to share with the rest of their educational and healthcare team to ensure that everyone's kind of on the same page with how a child is using their vision, to make sure that we're maximizing it across all of their therapies. Of course, if we find a need for glasses, we're going to give it. And you may also find that even though they're young, there's some of the conditions that some of these kiddos may have that also may require reading glasses at younger ages, and being able to know that to ensure that they're wearing the correct correction when they're working with you can be really beneficial. Protection to the eyes is always important. For those wearing sports, I might mention goggles, and making sure that we have good eye protection at all times. For those who are, getting glasses, I think it's important that the patient's, there for the glasses selection. We want to make sure it's a frame that they like. We want to make sure that it fits them to their face. And then whenever it's time to get it, we want to make sure it's adjusted perfectly for their face to reduce any kind of discomfort from the lenses pressing on the lashes, or the need for less pressure behind the ears. Use of a strap can be beneficial in some cases, but then there's some others who really benefit from kind of that more wire hard temple presentation. I think what's important is kind of making sure you have flexible and durable frames, especially if you have younger, rowdier kids, just to make sure that they can withstand all the things these kiddos are getting up into. We've mentioned a few times tactile defensiveness, and I think in those instances, what can be beneficial is a desensitization program. And oftentimes I'm looking to OTs, TBIs to kind of help out in these areas. And, as you all know, desensitization program is really, looking at kind of helping patients overcome fears, phobias, general anxieties around different aspects. And in this case, the eye examination. Ultimately, our goal is to make sure that the patient's feeling comfortable and willing to participate by acclimating them to the task and activity that we're doing, to really increase that, sensory tolerance and increase their engagement with the examination. These can be things such as glasses, where I've spoken to many people where it's like, hey, start with a play pair of sunglasses. Can we get the child to hold on to them? Great. Can we get the child to touch them to their face and it's fine? Great. Can we get to a point where we have them on our heads? Super. Can we get to a point where we're able to wear the glasses, even for a short period of time, before being able to get to the point where we have that full-time wear, which is the goal? This is similar things that can be around, such as allowing the eyes to be touched. I've spent some time with kiddos just working on being able to touch right on their forehead and slowly getting down lower, as well as accepting eye drops and practicing with just some dry eye lubricating tears in order to make sure that we can ultimately get to that point of dilation. Now, of course, if they have devices, or we feel like there's a device that would be beneficial to them, either educationally or vocationally, we'll probably recommend it. I always say, it's important to make sure that we find a purpose for the patient to use it. It doesn't necessarily have to be something that's academic, but slowly getting their buy-in to be a part of it, and then increasing their use of it can help utilize and encourage that use of devices. There's lots of thoughts around, should it be an optical device such as a magnifier? Should we look at electronic devices? And really, I think it kind of depends on the individual, as well as some other considerations, things such as our motor ability, what kind of posture is needed in order to maintain use, especially prolonged use of some of these things for those tasks of reading that they might be using it for. Now, I'll often be giving, especially for those who are already looped in, giving referral over for those assessment with our vision educators. So our teachers for students with visual impairments who are, of course, certified teachers who've done extra work to really meet the educational needs of children who have visual impairments. This, of course, can include things like functional vision assessments or learning media assessments or cerebral visual impairment assessments, as well as some of the more one-on-one tasks of, are we making sure it's accessible for the classroom environment? Is this child someone who needs to read Braille and receive that instruction? Are all kind of the areas that I see our TVIs working on with our students. We, of course, know our orientation mobility specialists are going to be working with those navigational skills to make sure that, depending on what the diagnosis is and kind of how one's using their visual function, make sure that they're able to use their visual system to the maximum ability that they can to be able to travel safely and efficiently. And then finally, our assistive technologists will be working on things like hardware and software for those with visual impairments and kind of making sure that the individual is able to utilize and have access to their assistive technologies to remain as independent as possible. So as we start to wrap on up, I always like to hear, or I get the question, what point are we concerned about vision changes? And I think, especially, again, for a population where it might not be as straightforward in communicating some of their concerns. And I think ultimately, looking at changes in the visual function as well as the behavior. Was there something they were able to do yesterday that they are no longer able to do for no other reason? And it can be as benign as increasing eye rubbing and eye poking without, any allergies or other external causes. We could see difficulty with navigating, bumping into objects that they otherwise have easily avoided or should be easily avoided. I mentioned earlier about regression of some of these skills in order to maintain that safety when there's a loss of vision. We also may hear about things such as eye pain or complaints that the room is darker, and then again those flashes in the peripheral vision or floaters in the or any loss of vision are, of course, very concerning things that we hear about and want to make sure that we get assessed immediately. Awesome. So as we wrap on up, I did want to provide a few resources. The first one is lots of different eye care places within the state of Massachusetts where I work in order to make sure that for different individuals who provide care to children and older individuals with disabilities across the Commonwealth. I always like to also call out the Special Olympics, which of course has our Healthy Athletes program that's providing free health screenings and education to those within the Special Olympics program. I'm happy to say that we are working on getting the Opening Eyes Vision screening back up in the next couple of years, and I'm really hopeful that we are able to provide this resource once again within Massachusetts. Educational resources that I like to make sure that individuals are aware of include the expanded core curriculum. And this is coming out of Perkins, kind of looks at 9 different kind of areas that we want to make sure that we're addressing with our students with visual impairments to ensure that they have the most independent and successful way forward as they start to age out of the school system and into the community. These things go from things such as compensatory and functional academic skills, orientation mobility, self-determination and independent living, and career and education. Again, really working to make sure that we have a full, well-rounded resources for our students. Several different resources I provide include the American Foundation for the Blind, the World Institute on Disability, as well as CDC's Disability Inclusion and Overcoming Barriers. And then here I have pictured a book, Children with Visual Impairments, which I think is an excellent guide for parents, for those with vision impairments, as a guide to kind of that IFSP, IEP process for these kiddos. And then finally, a couple of my favorite resources, and these are less, these are more just stories in general to kind of connect and learn more about different disabilities. The first one being Special Books by Special Kids, which has different interviews of individuals with varying disabilities on YouTube. And then Positive Exposure, which we have pictured here, was a work out of to provide a lot more beauty and focus on individuals with vision impairment and with disabilities in kind of that modeling space. So, perfect. These are my final resources, and I am more than happy to go through any questions that anyone may have popped in during. Yeah, perfect. Thank you for the question. The DEM, we kind of get, once we do the testing, we kind of get a couple of different pieces of information from it. One of them being, we kind of categorize the outcomes into 4 different outcomes. One of them being like, hey, you have no issues with your visual ocular motor system. Congratulations. The second one being a concern around automaticity, or kind of that ability to automatically do things over using the eyes and being able to kind of call things on rapid recall. Those aspects of the DEM include numbers that are vertically aligned instead of horizontal, as we read in the English language, just to kind of look at that rapid recall. The third area that we can see an issue in is a concern with the saccades, or those accurate eye movements. And this is where there's a concern with kind of, as we read horizontally, either reading too slow, skipping around, missing letters, adding in letters, numbers, I should say. And finally, we can see a combined where there's concerns around both the automaticity portion as well as the saccadic portion of the DEM. And then from there, we can provide recommendations around things to either modulate things to make things a little bit easier for visual search, or we can talk about exercises to work on making those eye movements a little bit more accurate.
Very good. All right. Next question coming through. Can you talk a little bit about modifications or strategies for those who may struggle with maintaining visual attention for tasks?
Yeah, I think when there's difficulty maintaining visual attention, I think it's important to find out, if it's possible to find out what is the cause that's kind of bringing the visual attention away. Is it because we're in a really crowded environment and it's like way overload and I'm just going to shut down my vision? We would want to make sure that we're reducing the complexity of the space, or we're making sure that's not as busy whenever we want that use of vision. Is it a distractibility thing? Are we, engaged, but oh, hey, there's someone walking down out in the hallway? Oftentimes I'll talk about making sure that positioning in the room has the back-facing areas of high traffic, such as those busy hallways. There's also concerns around, visual fatigue, and kind of depending on the etiology, we can see that visual fatigue come up pretty quickly and impact that use of vision. In those instances, can we provide increased breaks? Can we give more time to process things visually? Or can we do a more multisensory approach and see if we can use auditory approaches, text-to-speech and things like that, in order to still be able to access what we need to access whenever that vision's difficult to be utilized for one reason or another.
Good. All right. Next question. Any tips in helping kids with severe visual impairments in knowing the direction to walk towards? Use of whistles, clickers, claps, voice. How practical will these be as a child grows older? Child refuses to hold on to pre-cane. Thanks.
Yeah. Hard to say that. I think this is actually falling into y'all's purview a little bit more than mine. I feel, you know, is there something that is engaging that we can get the buy-in for the child? I can appreciate a whistle or a clicker being very quick in kind of situation, or do we need to be like, okay, we're going to play the CoComelon theme song over and over and over again, and that's something that's much more able to orient to. I think finding that kind of buy-in and at least getting things started, to get things started is a good move. I think transitioning that over, into being something that is a little bit less involved, into making sure that the skills continue to go, might need, maybe some overlapping kind of ways in how it's presented over time, or perhaps other supports, into kind of starting to orient that. That said, if we're not also using like maybe bright lights, especially if we're depending on like the lighting situation in the area, and the level of vision of the child. If they're able to perceive lights, that might also be an impactful approach that can help orient in low vision.
Very good. All right. For a child whose eyes jump up, down when crossing midline and when just walking and skipping, where would you refer them? What type of specialist?
Absolutely. I think that would warrant a look at from a pediatric optometrist. I think with basic eye movements, you kind of have within your pediatric optometrist, especially in those that you have some more traditional kind of pathways where we do certain tasks and kind of follow regimented things, and then you have a more developmental approach, which also includes my more full body kind of approaches and things like that. I think both will have a little bit of a different approach, but I believe both would be of good benefit in kind of providing some of that optometric care. So again, I think a pediatric optometrist who is familiar with binocular vision or eye movement dysfunctions, or a developmental optometrist, I think would be of benefit.
So, what environmental modifications are recommended for children with visual hypersensitivity to ensure they remain regulated and attentive during a 45-minute speech session?
That's tough. Could you repeat that one more time? I want to make sure I hit all the parts.
Yeah, so what environmental modifications are recommended for children with visual hypersensitivity to ensure they remain regulated and attentive during a 45-minute speech session?
Definitely. I think it depends on the type of visual hypersensitivity. Is it like a hypersensitivity to lights? How can we augment the room lighting? If we're working on a device, working on either lowering the brightness, putting a screen protector on, things like that. If it's a hypersensitivity, as in quick visual fatigue, I think, again, can we utilize or leverage other sensory channels in order to kind of combine and kind of get through to the child when vision isn't as reliable as we hope. Yeah, I think without knowing the exact kind of sensitivity the patient might have, I think it's, again, do we know where the etiology lies? What can we adjust to maximize that? And if not, what can we change about the environment or the approach to help maintain that? I think the biggest thing that I found, and this isn't necessarily from just this question but just in general, is a lot of people thinking that you need to like look to use vision, where I have many people who will take a quick look and then look away and actually be able to process better from just those brief glances. I've had children who had central macular scarring, but were getting in trouble at school because they wouldn't look their teacher directly in the eye, but that was because it was clearer for them to see using their side vision rather than their front vision. So I think also kind of considering some of those aspects where vision doesn't necessarily always have to be on, to make sure that just because vision isn't necessarily on or looking like it's on doesn't mean that they're not taking in the information.
Very good. Can you comment on how students with autism best process visual input?
Yeah, I think, it's going to, again, depend on the individual. We find that increased time to process, just in general, give them a longer time to look and think about it and take it in and respond. We find that we do see kind of an increase in difficulty in kind of coordinated eye movements. So either kind of working on eye movement type situations or making things easier to visually find, high contrast, making it bigger print, things like that can be of benefit. I think, for your light gazers, as much as we can get them not to stare at very, very bright lights, I think will be of benefit. And try to think of other big thoughts. Yeah, I think just kind of making sure that they're given a little bit more time. And I think also what I have found is kind of giving the narration or the steps is also of benefit. So I'll say, hey, we have 10 tasks we're going to do. 5 of them are going to have lights. And they're like, all right, I know I'm going to be locked in for a little while with the lights. Can also be really beneficial in working with kids on the spectrum.
All right. Can you talk about the strength of the research behind behavioral optometry?
Yeah, absolutely. I think that's the tough part when we look in vision therapy in general, is that there is an unfortunate large lack of dedicated research to it. a lot of even the kind of big meta-analyses that are looking at a lot of different things are like, well, they're there. And I think that's, definitely reflected on us, myself, I should say, optometrists and other folks working in the binocular vision world to continue to move that movement forward, move that research forward. You'll often hear that some of those classical vision therapy techniques do have that kind of backing with the research, especially for those treatment with convergence and sufficiency. And as someone who treats that as well, I certainly have, been like, all right, we have this diagnosis, we can get it covered, let's do it. But that's only one aspect of so many more pieces of that binocular vision system that can be worked on. So I think, ultimately there needs to be a lot of movement forward. And I'm actually really excited. In either late March, early April, I'll be going to the OVDRA conference, the Optometrist in Developmental Vision Sciences and Vision Accessibility, something like that. They just changed their name. They used to be called COVD, and they had to change their name for obvious reasons. So I don't know their new name, but I am increasing kind of my area in this and kind of hopeful to see where we are on especially those more developmental behavioral optometry research avenues.
Very good. All right. Should a student who has difficulties with eye saccades see a developmental optometrist?
Absolutely. I think things, strabismus, anything with our convergence, divergence, accurate eye movements, that's kind of beyond, the simple kind of scanning training or tracking training, I think would absolutely benefit from a developmental optometrist.
All right. Have you seen many kids with CVI, and what would you suggest to help with their visual attention?
Absolutely. So a lot of my work is actually within the realm of cerebral visual impairment or CVI, and is a lot of the patients I see over at our Perkins School. I think a resource I really like is cviscotland.org. And I think they do a good job of kind of taking out different areas that vision can be impacted in CVI. And I think looking at those exact kind of areas is really what's going to guide how we can help them. So big things overall that we can see help with our CVIers is increased time, increased processing time. We also see kind of a reduction of complexity, either how many things we have on a page, how many people are in the room can be impactful. We also see that impact on novelty. And again, that can be novel materials that they're being presented with, novel toys, novel books, or novel environments and not being able to process their vision as well in those new environments. So I think, it's a lot of reduction of complexity and kind of going slow, but there's a myriad of ways that CVI can present itself, and ultimately it will depend on how CVI itself is impacting the child.